Dr. Patel, welcome to the Vagina Doctor Podcast.
Thanks for having me today.
It's great to see you here. You're the founder of Central Drugs Compounding Pharmacy, and since 1999, you've worked with functional and integrative practitioners with attention to HRT for men and women. You've also written a book about glutathione, and we'll discuss that as well. But I'd love to know the story of how you got where you are, just your background and the things that make you tick.
Absolutely.
Why are you doing it?
Yeah, and you have an infectious smile. So when I look at you and you're smiling, I just want to smile, which is great.
Okay.
Oh, thank you. Appreciate it. Again, first of all, thanks for having me here today. It's an honor to be here. My career started very early on after graduation from University of Southern California. Being one of the top schools in the nation, they prepare you to conquer the world. They prepare you to do the best that you can. But the world has a different plan for you. After graduation, when I first came out, I thought I can change the world and how medication has been treated in the United States. And I was told that all you can do is manage people's problems, and you're not going to solve any problems anymore. So that was a blow to my career very early on. I said, what am I doing? I still had student loans to pay, bills to pay, family to take care of it. So you go with the motion, but you can get sucked into it really fast if you don't have your prize on the goal. And so I had to have my eyes plucked away from what I was supposed to do, what I was doing to what I was supposed to do, which was to find a solution for my patients. And the first solution I found out was, hey, I can just do some customized medicine. And very early on, I'm talking about 1990, I graduated from 1996. By 97, I had my first compounding pharmacy already ready to go in East LA. Yeah, in Montebello, we had the first compounding pharmacy over there. I said, you know what? I'm just going to do whatever it takes to start baby steps, but just do what I'm here to do. And so we started that process, and that really took off because it gave me two things. One, it allowed me to use my knowledge, but the second part, which is much more fulfilling, was how patients responded back to us as, hey, this thing is really helping us. Can you do other services like these? And
if I might ask you a question, prior to doing that, were you not not working in a compounding pharmacy?
Yes, I was. So 1992, I started working in a compounding pharmacy, but you know what you're doing there, but that's just to make ends meet. You're just doing that. You're getting experiences. I think, this is great. But the guy that I was working for in the Bay Area was doing a good job. It's just that it was very hard to make ends meet. It's very difficult. And so when I graduated, I said, hey, I said I should do it. I should not do it. Very difficult for me. But when I got my own pharmacy, I said, this the first thing I'm going to do is start introducing compounding pharmacy in East LA.
Yeah, great. Does it sound okay?
Yeah, we're good.
Went a little strange. And then I suppose that it became clear to you that one of the big areas of interest for compounding pharmacy was in hormone replacement therapy for women. Is that men and women?
That was my background, because the pharmacy I worked at while I was an intern was doing hormone replacement therapy. But at that time, we were just making medicines and basically providing the patients, but nothing above and beyond that. My goal was a little bit different. I said that, hey, I would provide the medication, but I don't know why it's working, how it's working. And if I don't make improvements, then it'll still be status quo all the time, and patient may not get the outcomes out they deserve to get. And so I took a step further and says, hey, you know what? Let me find out more about it. And so by the year 2000, I started doing my own seminars and educating patients and doctors at the same time about how to use hormone replacement therapy effectively.
Yeah. And keep going. It's fascinating.
Yeah, it's one of those things that at that time, the doctors were not interested in learning new techniques.
No, that's the thing. That was probably a hard thing to convince people at that time. Yeah.
And my father who's my inspiration even today's date, he told me one basic stuff. I said, there's always an easy road and a hard road. The hard road is basically, it's hard to go on, but it gets easier as you travel. And at that time, the hard road was to go after the consumers and educating them. I said, hey, this is the right thing for you. Where they said, wait a second, who are you again? I'm here to listen to my doctor. Why should I be listening to you again as a pharmacist, mister? I'm sorry. It was one of those very difficult things for me to start educating patients because at that time, patients are not ready. And even today's day, if you think about today's day, most patients are still not ready to take healthcare in their own hands.
Right.
And convincing them 25 plus years ago that, hey, you should be taking care of your own health and nobody's going to help you. So, wait a second, I have insurance.
Yeah. Yeah. And so with what you're doing right now at your pharmacy, you're doing probably mostly creams, right? Compounding creams.
So what I've done over the years, I have made creams, gels, capsules, injections, pellets, sublingual drops. I've done all kinds of different things. And then I have to look back and see what's working, what's not working. And I can only go back to my physicians that have supported me for all these years to say, hey, doctor, what is working for your patients? Are the patients buying the medications every single month? And if they are, then I know something is working. No one's going to pay out of pocket for a medication that doesn't work. So I started analyzing all those datas and for the first 5 or 10 years. And when I got the data as to what's working, what's not working in that patient population, I started educating physicians about, hey, this is working for this doctor. You should try it too. And so today, 25 years later in this business, I spend 99% of my time educating physicians and exposing them to different protocols as to what's working for some other physicians out in the marketplace today. Because if you're a doctor by yourself in one place in remote part of this country, you're only exposed to the patients that you see.
Yeah.
How do you get to see what somebody else is doing in New York or Chicago or Dallas or LA or anywhere else? And so I am that bridge or the gap that's filling that void and educating physicians that, hey, this is what's working for the patient population. You should at least give it one shot at it. And once you try it out, you can adjust based on how the outcomes are going to be.
Well, not only did you have to persuade physicians to do something different from what they were taught in medical school, but there was the Women's Health Initiative study, which basically stopped the whole business of hormone replacement therapy or put a huge brake on it around 2002. And we've all been struggling against that. And I think finally we're making some headway here that now HRT is a recognized form, but even so many of the primary care physicians in this community in Santa Barbara, they're trying to get my patients off their hormones. They say, oh, you've got to get off those. They're going to give you breast cancer. And it's really horrific that it takes so long to change something in medicine. And I can see not only did you have to get over even the physicians that were forward thinking enough to talk to you, but you had the patients who were saying that they didn't want to do this anymore. It's really been a struggle, but because of people like you, making it easy for people like me to have a product to sell to a patient, to give to a patient, or to prescribe in this case, it's been so helpful. And Harbor Compounding really helped me a lot of the way, and I learned a lot from the pharmacists there.
It's amazing to being recognized that pharmacists are out there helping other healthcare providers to basically better manage medication needs. And you're right. Even 25 years ago, my first doctor that I convinced him to start working with us was a retired physician. He was 74 years old. He just sold his HMO practice, Southern California. He was done with it. And I told him he was golfing his life away and he was bored to death after a couple of years of golfing. He says, I'm bored now. I said, okay. I said, what do you want to do? I said, I want to do some other type of medicine. I want to do anti-aging medicine. And I goes, what the heck is anti-aging medicine at that time? I plugged into my hormone replacement therapy that said, hey, that should be the best thing to do can we get the endocrine system all balanced up and hopefully they'll slow your aging process. And he bought it. And
that's great. And is that about the time you got into doing the glutathione and things like that?
That was the second part, right? While I was doing the hormone replacement therapy, we were attracting clients all over the country that were more interested in about beyond just HRT or BHRT,
Yeah.
what we
Yeah.
call it. And I was hired by another physicians group to basically work on glutathione, actually work on vitamin C, and see if I can make that into a liposome technology product. But back in 1999, there was no liposomal products available in the vitamin world. So I was hired to do that and basically said that, hey, can you work on vitamin C? And while we were successfully made the product vitamin C in a liposome technology, lyophilized the liposomes and put them in the capsule forms back in 1999 or early 2000, it would have costed you $1 a day. Now, today
Oh,
doesn't
wow.
seem like a lot of money today, but 25 years ago, $1 a day, just to give it put things in perspective, at that time, vitamin C was available for $2.39 for a bottle of 100 pills.
Yeah.
Oh, wow.
And I'm telling you that no, instead of $2.39, I'm going to charge you $100.
Yeah.
It's unimaginable. People cannot even comprehend that how would medicine be so expensive in the first place. Anyways, I was too far ahead of my game at that
Mm.
point, and I could not convince anybody to buy the product. But then that led to me to say, hey, what is more powerful than vitamin C? That's when I started working on glutathione. I said, hey, why am I working on vitamin C? It's not even produced by humans. We don't make vitamin C. We make glutathione to do with all these problems. Why am I working with a subpar product to begin with? I should be working on glutathione.
Exactly.
And so that's when I started process in early 2000s to work on glutathione. And within a couple of years, I found out that the liposome technology product was not working on my patients. Since I already had already a sterile lab in Southern California, we started making intravenous form of glutathione immediately.
Oh, wow.
We made that in 2001 and onwards. Of course, the results were not super good. They were short lasting, right? It was just something that only lasted for half an hour or so only. And so then a few years down the road, I started, keep in mind, internet back then was sketchy, right? With a dial-up
Yeah.
modem, takes you a long time to get
Oh, yeah.
pulled up. But so a couple of years later, we were doing research and we found out was in 1991, there's a study done that the glutathione actually, when you give it intravenously, only stays in the plasma, and the body filters the plasma out in 5 to 15 minutes, and everything's out in the urine in that time frame.
Wow.
And so I noticed that, but I couldn't figure out why it was happening. The study was already done a decade ago for that result. So anyways, I still have bills to pay. So I'm still making the product, the intravenous, for another 20 more years. But behind the scenes, I was actually working on a different technology to see if I can stabilize glutathione outside the human body and somehow deliver it inside the body, either by mouth, through my nose, suppository, inhaled solutions, topical, whatever route it takes to get it inside your body. And that system was, in fact, perfected in 2007. And when the system is so perfect is because what we created in 2007 and what we have today in 2025 is actually identical product.
Wow.
No changes,
Wow.
no
Yeah.
variations. I couldn't even change one thing from inside.
And what method of delivery is that?
Oh, the method happened to be topical.
Okay.
That's not something that Americans like everything to be pills and injections. If I was in Europe, they'll love me because they'll want everything topical. But in the United States, they want everything in the pills or injections only. But unfortunately, the pills and the shots did not work. They were they have been broken down. So the only route left for me was a topical route, and that actually did work. We filed for patents back then, and by 2019, we got for our first patent approved. And by today, we already have 8 patents approved on this delivery system, as well as compositions and getting glutathione intracellularly.
But it's topical.
It's
Yes.
Is that
topical.
right?
Yeah.
So it's a cream.
It's a solution.
It's a
It's like a
solution.
liquid. It's a liquid that just sprayed on and you just rub it in. Takes about 30 seconds to 2 minutes at the most. And it's in front of your eyes. The whole thing goes from liquid to completely gone inside
And
your body.
where do you spray it?
So I usually spray anywhere there's a less hairy area or preferably
Yeah.
no hair. So I shave my arms. I shave my arms all the time. So I put
Okay.
it in my arms, I put it in my belly. We have done 2 clinical trials. We've done 2 human trials. One was we applied it on the arms, and the results, we had the results, and we compared that to the results we have when you apply it to the belly, and the results are actually identical. And so what we found out was it doesn't matter what part of the body you apply to, it's going to get absorbed through your skin. And this is way different than hormones. Because when
Yeah.
people think about hormones, oh, I apply on my wrist, I apply on my inner thighs, inner arms, things like that. Because the hormones, when we apply the hormones, we are actually using passive diffusion through your fats layer to get it inside your body. What we have done with this technology is we have bypassed all those things and went to the water channels of your skin and go through that.
Okay.
And to make that happen, the particle size was supposed to be less than 1 nanometer. That was my first technology that we developed to twist the molecule to make it small enough to get to the cracks of your skin.
And so what are people finding using this product?
Oh boy. Oh my gosh. So that's my book, The Glutathione Revolution. The book that I
Right.
wrote, The Glutathione Revolution.
Yes.
That
Yes.
book was, in fact, my first 12 years of research. I had no idea when I'm going to launch the product or the company ever. So before anything that happened, I was writing the book out because I was trying to gather information as to how it was helping the people. Glutathione by itself, if you think about it, it's what is money? What can money do for you?
hmm
It's not what can money do for you. It's what money allows you to buy. Let's say, what does glutathione do for you? Glutathione is a currency in your body. The only currency you have in your body is glutathione. With glutathione, you can get rid of oxidative stress. Oxidative stress is linked to all kinds of diseases in the world. It can also activate your CYP enzyme pathways for conjugation. So now if you have all this hormone metabolites in your system, you can literally get all the metabolites out of your liver. And so that way you can continue doing your ongoing hormone replacement therapy without having the potential of the metabolites getting accumulated so you can get breast cancer from it or uterine cancers from it. So that's another thing that can does. Oxidative stress is also something that is linked to skin disorders like age spots, liver spots, things like that. Those are all physical changes that happens in your body and the aging process that happens. Imagine glutathione being there to nullify all the stress down to zero within hours and then keep it
Yeah.
that way for the next 4 to 6 hours. And if day in, day out, maybe 2 or 3 times a day for a little bit longer periods of time, yeah, of course, you're not going to see instantaneous results. In some cases you do, but most cases you're going to wait for 2 to 4 weeks to see some results. But by the time you're using it for 2 or 3 years, the whole thing is changing. Your whole perspective on life is changing because now for the very first time, you're seeing that you're not aging. You're seeing that you're having more energy. You're seeing that you have more flexibility in your body. There's no pain. You think better. Your mental clarity is getting better. Your visions are getting better. And all those things, it's a slow progress. Glutathione is doing anything. What glutathione is doing is getting rid of the stress in your body. When the stress is gone, all of a sudden the body starts repairing and restoring and rejuvenating.
So you would, excuse me, you would recommend 3 treatments a day, every day for everybody.
So I
Is that
have,
fair?
I only do
It
2
sounds like
treatments.
it.
It's better for that, but it's very difficult to do even 2 treatments per day.
Mm.
If we can do 2 treatments per day, I'll be very happy with it because let me tell you another thing about glutathione. Half of the glutathione gets recycled. Any glutathione that is oxidized because of free radicals, that oxidized glutathione gets to be recycled again back to glutathione again. So 50% of the glutathione, if in a normal, healthy human being, gets recycled. If that is in the application for 2 to 3 months, could hit you steady state. And that way, a single application may last you 8 to 12 hours.
Okay.
So
Oh.
twice a day dosing is what I recommend to most people. Now, of course, if you have an acute problem that you need around the clock coverage, I'll tell you to use it 4 to 5 times a day, every 4 to 6 hours for about a day or two. And we have done that for people that have shingles. Shingles is not a viral infection. Even though it's a virus causing the shingles, the virus you already had in your childhood when you first got
Yeah.
chickenpox, maybe. But what happened was your immune system went down and the shingle outbreak happened, right? If I can rebuild your immune system back to normal, the shingles should go away immediately. And that's what we have seen, right? By giving glutathione, it activates your immune system. And within 24 to 48 hours, your lesions, your pain for little shingles are completely gone. Now,
this is very exciting. Okay. So I don't want this to sound like I'm doubting this, because I'm not. But are there ways that your patients are feeling better because of this? Other parameters that indicate that this is beneficial from an anti-aging point of view? Does it do anything to telomere length, or does it do anything to the high sensitivity C-reactive protein? Any other measurements that we look at as being important to evaluate?
absolutely. Nutrition is number one of the hallmarks of aging process. And literally, we have not published the human trials for telomeres. We have doctors using it for telomeres lengthening, and they have reported back to us that have happened, that part. I can tell the doctors, I said, can you please publish your findings, even if it's one patient trial? It's so much easier to get this trial. And most physicians, they're great at seeing patients and evaluating and treatment them. But if you ask them to write a case report and submit to some journal to publish it, they get freaked out. They get, oh my God, I'm not sure. The first article, Dr. Utani wrote it out at the university. He's 70 plus years old, and his first research paper wrote, and he's a professor at the university, was after he was 72 years old, right?
Oh,
Now,
wow.
today, you cannot stop him from writing, but his first article he wrote was at the age of 72. And he told me right off the bat, I said, Nayan, you have no idea how daunting the task is to write one article, because to write one article took him 1 year. 1 year for the first one. After the first article, he's written 6 different articles in less than 6 months.
Wow.
Fantastic.
So all I can tell people is urge, please write. They give me testimonials on my website, but that doesn't mean anything until you publish a paper. Even if it's the N of 1, I don't care. What we have measured is MDA levels, which is malonaldehyde levels. We were able to reduce the malonaldehyde levels within 4 hours of single dose application. We did a 30-patient double-blinded placebo-controlled trial to show that.
Wait, what is that?
So MDA is
that?
malonaldehyde. That's one of the oxidative stress markers in your body, and most of us have elevated MDA level.
And how do you check that?
It's a blood test.
It's just a blood test?
It's a blood test.
And what's it called, the blood test?
MDA level.
Yes.
MDA
level.
Yeah.
Oh.
Yeah.
Okay.
The thing is, nobody measures it, because the thing is, there's nothing you can do to affect it. So
Okay.
if you cannot improve it, then why test it? But now you can. Now within the 4 hours, we can bring it down. So now we can test it. There's another marker called 8-HNE. That's another markers that we test. CRPs and homocysteines are secondary markers, and those are also good to have it. But those CRP can be affected by a lot of different things too. So it's not just an indicator of your stress. Could be because of infections, could be something else as well. It could be arthritis, who knows? And so I'm looking for markers that are not specific for glutathione, but I'm looking for a lot more markers and see, is it affecting every one of them? ApoB levels, triglycerides, your A1C levels,
Mhm. Yeah.
all those things. Because when your oxidative stress starts getting better, all these markers should be coming back to normal. And you should notice that. Like, for example, even an ALT, AST level, which is a liver enzyme, if they are elevated, that's an inflammation marker. That should come back down to 6 to 8 weeks. But just because the ALT, AST levels are back to normal doesn't mean your liver is back to normal. That's just your inflammation is back to normal. The liver will still be injured, and we still have to keep on doing more and more to fix that. But the inflammation can come down right away. Okay, these are all the markers that we have seen over the years on how it has helped the patients.
Okay, so I'm being convinced by what you say.
Almost.
I love it. Okay, I for most of my career, I've been in Santa Barbara as a gynecologist for almost 47 years now.
Okay.
And I've always pushed the envelope somewhat, okay? Whether it's a minimally invasive surgery or hormone replacement therapy. When I see something that really works for people, I get on board. And I definitely look at these things optimistically. And that's how I look at this. So if I want to prescribe this for a patient, how do I do it? I contact Central Drug
It's an OTC product. It's over the
Oh,
counter.
okay.
Yeah, it's
Okay.
glutathione is a completely new product. It's a topical product. They can go through Central Drugs. They can go through another website. They can just buy the product directly. The brand name is Glutaryl, Glutaryl. But
Yeah,
again,
no, I have all the
You got that.
information for
Okay.
yeah,
you.
you
Okay.
can get to the
Good.
pharmacy. If you get to the pharmacy, and if you're a patient of ours, then you usually get a discount from us at the pharmacy. So
Okay.
it's always good to buy at the pharmacy for sure.
Yeah. Great.
That's good. And what if you have a patient that is doing something to lower their immune system? So they might have a condition, a pre-existing condition. Could they still be on the glutathione?
So when you say lower the immune system, I'm assuming that you're talking about patients with histamine issues, hyperactive immune systems.
Yeah.
And
Or on medication for MS, for instance.
yeah, so all medication for MS, and that's a great question because we have a lot of patients with MS on glutathione itself, and it's so the glutathione is not to just activate and go crazy on your immune cells. It's not just that
Okay.
to increase the WBC. It's not just to increase your IL-2, the IL-12s, interferon gamma, TNF alpha. But what it does, it modulates the immune system, right?
Okay.
If you're hyperactive, it basically is because there's some kind of antigens or something in your body that is causing the problem. So the glutathione can aid in the conjugations and the elimination of those toxic chemicals or materials like that. At the same time, it can also modulate the immune response on its own as well. So either it's low acting or hyperactive, either way, glutathione it's like an adaptogen. It can help regulate that part. By the way, it's the glutathione, 140 years that we have known about glutathione, we still haven't figured everything out yet. We have the technology to deliver glutathione intracellularly until today. So all the research has been done in the past, and I have put this into a bunch of AI models. And guess what? The research that's coming out is based on old research, and the information that we're getting is not correct as of today's date.
Okay.
So what that means is that we may have to repeat some of the studies again to see what other outcomes can we get from there.
So if somebody is getting glutathione injections,
Uh-huh.
and what is your opinion about that? What are they actually getting with a glutathione injection?
So all glutathione supplementation today, IVs, inhaled solutions, suppositories, liposome technology, the way it works right now is like taking any other peptides. All peptides that you take, glutathione being a tripeptide, your body will actually break it down into various amino acids, reabsorb the amino acids that your body needs, and then use that to conjugate your own peptide again. Now, when it comes to glutathione, it can do that very efficiently. But if you're trying to make it, for example, semaglutide for weight loss, it's not gonna reconjugate into semaglutide again. It's just gonna break it apart. But the larger peptides are also signaling molecules, so they're bioregulators. So they send a signal before they get destroyed, anyways. When it comes to glutathione, the research has shown that all the glutathione that have been given in the past, the body breaks it down, reabsorbs the cysteine in the blood,
Okay.
and those you can measure after every IV injections. You'll see that about an hour and a half or 2 hours later, there is no glutathione in the body, but they'll see a surplus of cysteine in the blood. That cysteine is actually being used to reconjugate and make your own glutathione intracellularly. So they all work. The
Okay.
question is, will they work or not? They all work, right, to a certain extent. But it's like you're depending on your body's ability to reconjugate and make your own glutathione. And if you're, let's say, 50 years of age and your capacity is only to max and make 80% of what your body's needs are going to be, no matter how much supplements you give them, the max you're going to reach is 80%. But if you want to
Okay.
go to 100%, you have to bypass something and give a product that is actually replacing what your body is not producing. And
Okay.
so when it comes to replacement part, unfortunately, there is no technology exists as of today, except for the one we have created as of right now to actually bypass the cell membrane, the skin layer to get intracellularly today.
What's been one of the things that I found fascinating about medicine over the years is the awareness that a lot of medications are actually good and bad can get through the skin. But I never thought that as a young medical student, that topicals just seem to be like, that's not going to do any good. But the
Yeah.
skin is really transparent. And you've created this system of getting glutathione in that way. It's brilliant.
The skin is a physical barrier, but there's so many ways to break the barrier to get inside your skin.
Yeah.
The issue is not getting through your skin. I thought that was the hardest thing for me to do, was to get through your skin. The harder thing was to get to the cell membrane. It's a chemical barrier. You cannot get through the chemical barrier. So we actually use the ACE receptors on the lipid rafts on the cell membrane to use that receptor to transport glutathione through that receptor, which is a
Wow.
very novel way of doing that part, because those receptors are for nutrients-based receptors. So we had to somehow mask the glutathione into making a sugar molecule. So the body thinks that they're getting carbohydrate or sugars, and inside stuffed is glutathione.
Yeah. It's great.
How long did it take you to make this product? Maybe you said that and I'm asking it again. How long did it
Yes.
take?
It took me 7 years to make the product. And then I did not realize what I had created until 2 more years after that. Because it was working, but I had no idea why and how and things like that. By 2009, I already knew what I had created, even though it was already made and ready to go in 07.
Okay. Wow. Great.
So how different subject? The FDA are trying to stamp out compounding pharmacies, aren't they? Or they're trying very hard.
Oh,
So
my.
congratulations on surviving to this point. But what do you see the future there? I was very disappointed listening to a talk from the North American Menopause Society, or now they call themselves the Menopause Society, about HRT. And they came down, they were talking then about how they got it into the body, what could be used and what couldn't. And the statement about creams was, well, they're not FDA approved. End of story. Okay? They would not look beyond patches, gel, some of the gels, yes, but only those produced by ProPharma. And a lot of the compounding pharmacies in Santa Barbara have gone out of business because it became more difficult, or there were too many restrictions put on them to continue to be in the back room creating a cream. Do you think we're going to get through this? Are we going to? What's
So
your
too.
thought?
I think so too. And the thing is, it's not about can we get through this thing. I think we need to work together to make sure that our focus is going to be on patients' health. And as long as our focus on patients' health, we always going to find a way to get through it. So
Yeah.
again, I said, I'm in compounding since a long time ago. I've seen all the waves from literally having 12 compounding pharmacies in the whole state of California when I first started doing business, to the peak we had over 400 plus compounding pharmacies just in the state of California, to now down to less than 100 remaining now, right?
Yeah.
And so I've seen the whole wave of all these things. And I was a warrior even back then when I first started doing intravenous compounding, sterile compounding. I literally fought for the rights of patients, making sure they have access to compound medications until 2020. And in 2020, when my glutathione patents got approved, I hang my hat on the sterile part, because you know what? I have a different mission in life now.
Yeah.
I would love to give access to the patient's health and make sure they have sterile medications available. But I have a mission now. I have to save the patients not from getting access to medications that after they're sick, but see if I can save them from getting sick in the first place, right? So I have
Absolutely.
a mission. But before that, I'm still an advocate for compounders. I still go to Capitol Hill. I still go to the state association meetings and basically fight for the rights for consumers. I just had a meeting with one of the officials in the state of California. There are only 3 or 4 officials on the top of the California governor's office. And I met one of them in the hope that they have restricted the use of injectable glutathione in firefighters.
Oh, wow.
And I met with the officials, saying that, hey, yes, you have done that part, but guess what? Even better technology does develop in the compounding pharmacy, which is a topical glutathione, that we can help the firefighters. So compounders are not just making medications according to the patient's needs are going to be, they're also doing hardcore research. They're trying to figure out a better alternatives. They're trying to figure out a safer alternatives for the consumers. And we got to protect the industry because from there, this was born. If you didn't have that access to that, this would never have happened.
Right. So thank you.
Yeah.
Thank you
And
for
so,
doing that.
yeah, absolutely. And your question, the last question was, is there a hope for the compounders? The answer is absolutely yes. Resounding yes. Please do not go out of business unless you have a whole different agenda. But if you're there to help your patients get better medications, have access to medications, there's absolute future for that. And the people that are getting out of business are the ones that are actually refusing improve the standards. And that's what the thing is, right? Keeping the standard. Like USP 800, which is to protect the employees from hazardous compounding, the law was passed in 2018. Guess what? My lab was built in 2010, 8 years before the law was passed. And my lab back then was USP 800 compliant.
Yeah, great.
8 years before the law was even passed. If the compounders can think above and beyond to protect the employees, to have safer medications for the consumers, do the right thing, the future is there for all of us.
What do you think? Sorry, my mic is
Yeah, I'm in
not
trouble with
staying. It is bad. What do you have an opinion or any thoughts about the role of the pharmacist and in compounding pharmacies, how they are, some pharmacists are taking on more of a doctor role and getting in the middle sometimes of patient doctor care?
That is the worst thing that can happen to the industry.
Yeah.
When two conflicting information comes to the patient. Patient is a consumer, they go to the doctor, they go to the pharmacist, and they tell you two different things. That's the worst thing that can happen to any industry
Yeah.
whatsoever. And I 100% disagree with that the patient should have to choose who's right and who's wrong. I strongly suggest that physicians and the pharmacists work together, because once the diagnosis is done, really the pharmacists are the one that trying to find out how's the medication responding to this person or not.
Yeah.
Right? And understanding the intricacies of this whole thing. But at the end of the day, if something goes wrong, it's the doctor's license on the line, not the. And so, as much as the pharmacists would love to help the patients out, they cannot and they should not go behind the back of a physician, treating the physician's patients that's taking the patients, to tell the patient what's right and what's wrong for them. Because at the end of the day, that information needs to come as a one information from both the physician and the pharmacist. And if there's a disagreement, then talk it out before you talk to the patient. That's okay. That is absolutely okay. And I get calls. I only talk to doctors every single day because this is what I do. My pharmacist team will talk to the patients, but me personally, I oversee the doctors every single day. And all we are doing every day is trying to figure out what the right option for the patient is. Because when the patient get the medication and they get one message, either from the doctor or the pharmacist, the patient is going to be compliant, the patient is going to be happy, the patient is going to get the results they're looking for. And if they don't, there's a way to make it better, faster for them. But if they have to choose between the pharmacist and a physician, it's never a good situation. They should be completely separated. They should not be allowed to do the same time. I don't think so. And I know what the laws are changing right now, and the pharmacists are getting more and more involved and things like that. And if the pharmacist wants to take care of the patients by themselves and put their license at stake, go for it. Do it, right? But if you're relying on the physician to come back and take care of the patients, then it needs to be more collaborative. It needs to be more collaborative. And again, and some of the doctors doesn't want to hear anything. That's okay. Then you step away and say, hey, it's your patient. You treat the way you want to it. I will still give you my opinion to you if you need to. And what you do with the opinion is up to you. But the patient should never ever be confused as to find out to the true healthcare providers who should he believe or not.
That's great. I like the answer to that.
Quick thoughts. Pellets for bioidentical hormone replacement therapy. What do you think?
Again, this is just my opinion. Don't hang me down for my own opinion. So we made pellets from very early on up until 2013. And in 2013, what we had was company pharmacy were started to basically start reporting to FDA and MedWatch program as to see how many problems are there. And so we were not keeping tab of every single thing until 2011. So we started keeping tab of every adverse events that was coming through. And we found out that we had a lot of adverse events with the pellet therapy, i.e. could be from insertion, just the surgical procedure was not done correctly, to majority of the cases were that in the first 3 to 4 weeks of the pellet insertion, patients had a humongous amount of side effects, bleedings, headaches, breast tenderness, all kinds of issues that they were having. And so my thing was, how many of them are critical? How many of them were not critical? So we started keeping a tab of all those things. And what we were looking at is to finding out is why this was happening. And even though the company pharmacy was making pellets, the pellets were not compressed enough, or maybe the formulation was not good, that it lasted the patients at least 6 months. Some patients may only last them 3 months. Some patients may only last them 4 months. But regardless, what was happening was the patients were getting a huge dose in the first 30 days and then taper the dose down over the next 2 to 3 months. And since I could not control and I had no ideas how to control it correctly, we basically stopped making the pellets back in 2013. The other thing that I was looking at the literature is that the continuous form of hormone replacement therapy was also a problem. It could be putting a patch on. That's a continuous form of therapy. Putting a pellets insert, giving injections, even using daily hormones with creams and capsules and all those things. The body may accumulate some of the metabolites. So if you have a diet full of cruciferous vegetables and you're eating those diets and helping eliminate those metabolites, you might be okay. Otherwise, there's an accumulation of all those metabolites that could be toxic to your body too. So anyways, so all those reasons, what I cannot control was the pellets, because that's a 6 months process, making the pellets at that time.
Yeah, the amount or the rate of metabolism of those pellets is so variable. I had a patient on one occasion that decided to stop the pellets and go to another method. And I said, well, we've got to wait until the pellet that you have isn't working as well. It took 2 years.
Oh my goodness.
Oh, isn't interesting.
It's
Yeah.
but and then she was fine in the end. It came down, and we then supplemented by some transdermal. I don't remember which one it was, but it was fine. But that was an eye opener for me. And the problems with pellets is really stacking of putting a pellet in when the other one hasn't really got down much of a level and it's still going. And estrogen seems like it gets metabolized less quickly than testosterone. So if you're doing estradiol and testosterone at the same time, they're going to be out of sync eventually. But these are things you just learn and you deal with, and variations. But one other question about HRT, what about the arrhythmic method? Whatever it is, of cyclical, of using progesterone just half the time, or as we've also tried coming from Santa Barbara and people I've been associated with here, there was what we refer to as the Wiley protocol, T.S. Wiley.
Yes, Wiley.
Yeah, I knew you'd know, Susie. But peaks of trying to mimic the female reproductive 28-day cycle. So it's great theoretically, it's great. I had a lot of patients that haven't tolerated it well, but I'm still intrigued by it.
For perimenopausal patients.
Yeah, I think so too. But what's your opinion about? Is that important to have those peaks of estrogen and peaks of progesterone in that 28 days?
So I go back as to how the nature is created for us, right? And again, if we can mimic nature, it would be great. If we cannot mimic nature, we would like to get as close as possible. That's the whole idea behind this thing. And both men and women, the number one hormone in both men and women is what? Testosterone. The highest amount of hormone in both men and women is testosterone. The ratios are way off. Men testosterone levels is like 1,000 to 1,100 versus females about 90, 95, right? So the ratios are very off, but the number one hormone in both men and women is testosterone. Yet we only talk about estrogen and progesterones. Why? Because those are the two hormones we need to procreate and to produce babies, right? So the reproductive hormones, which is estrogens and progesterones, are there and they're cycling up and down based on the FSH and LH surges. And it's all there to basically procreate and basically have babies. That era is gone. Once that era is gone, then the only hormone that you have the most of is testosterone in your body. Now, of course, we want to go back and say, hey, the research has been done that if your estradiol is between 60 and 110, did a Hertz trial, that you have the best benefit against cardiovascular protections, and against Alzheimer's, and mental health disorders and Alzheimer's and things like that. Okay, so great. So we have this one study that basically is irrefutable, FDA approved. They said this study, based on that, you should treat every patient to make sure the estradiol level is between 60 and 110. Now, besides that one study, there's no other studies that tells us what all the other hormones should be,
Right.
i.e. DHEA, testosterone, progesterones, pregniols, or whatever. There's no other studies besides that one study for the estradiol, okay? And estradiol was only there for sustaining, for basically helping for the follicular stage to basically get the eggs ready, and then the progesterone kicks in to proliferate the cells and get you pregnant. And once you get pregnant, the estrogen levels rises, the progesterone level rises, and in the absence of pregnancy, everything drops and you go back to normal. Now, that's the normal cycle, right? But Dr. Wiley, I call doctor, but she's an anthropologist, but it's true regardless. Dr. Wiley, she earned the degree as an anthropology, studying the human behavior and things. Is good that we want to mimic cycles, but the rhythmic was there for literally for pregnancy, for reproductive cycles. So yes, if you're using until the ladies hits menopause, I'm okay with it. But once you hit menopause, all you're looking for is a certain balance of hormones that are there to have you relieve of symptoms. That's number one choice. Number two is that, hey, to be 60 to 110, because that's have shown to have all these protections, and all the other hormones supporting that high levels of estradiol. And so, as a patient of mine, which takes all the hormones on a regular basis, it's difficult for me to give them one medication once a day, every day, and they are basically about 90% compliant, not 100%. If I give them 2 pills per day, they're down to 70% compliance. And if I tell them that you have to take a different dose every single day, based on your rhythm and your cycles and your app and whatnot, based on the moon phases, the sun comes up or not, you're going to lose these patients all day long. And these hormones could be extremely dangerous if they're not given the proper ratio at all times.
Right.
So back in 2004, this is post-WHI study, the book came out, Sexy Years. I don't know if you remember the book came out, The Sexy Years.
Yeah.
In Summers, for the book. And I thank her for that. I'm blessed her soul now, but thank her for bringing this out to the open
Absolutely.
and discussing this thing. And she worked with us for 2 years with my pharmacy and my team. She worked for 2 years with us. And of course, T.S. Wiley was pounding at us. I said, oh, you should do this protocol. You should do the protocol. I said, Dr. Wiley, as much as I would love to help you and to give a protocol to my patients, is patients that are not compliant. And non-compliance is actually more harmful to the patients than helpful. And to me, it's an absolute no deal. Out of millions of patients that we have served over the years in my practice, I have less than 100 people that have given them rhythmic hormones or Wiley protocols or whatever the thing is, and they have stayed compliant. It's 0.001% of the population. It doesn't exist.
Yeah, I must admit that I'm very frustrated with non-compliant patients and self-medicating patients.
Oh, by the way, I don't know but there was a Wilson's thyroid protocol that you take thyroid pills every day, higher doses, and after a certain temperature, you bring it back down again. Same rhythmic thyroid, and even though that was a little bit easier than the Wiley protocol, even that the compliance rate was less than 10%. It was very, very low.
You make a very good point.
I can share a couple of my success stories.
Please.
Yes.
That way you have those. The success stories over the years we have, again, we have tried all kinds of things. One thing is that the application site of the hormones matters. We started about 2009, 2010. Dr. Jonathan Wright came to Southern California and educated us that, hey, you should be applying all the hormones to the inner labia only because that has the absorption. But more importantly, you have less hyperplasia of the uterine lining, so it's better for the patients long term. And of course, me being a guy, I had no idea. I said, I don't know if the women are going to do it or not. That's your call to make. Give them the option. Trust me, you will not regret that part today. I'm talking about 16 years later today, this year, our number one prescriptions or number one patients that are compliant, that never to change medications, are the patients that apply the hormones to the inner label application.
Wow.
Low dose.
Wait, what hormone?
Just estrogen,
Estrogens.
progesterone.
You mean the creams?
Yes.
The HRT creams?
Yeah.
Okay.
Yes.
Yeah.
As compared to the wrist or inner thighs or lower abdomens, things like that, applied to the label application, I have never changed the site on them ever. Same
But how
site.
do you put both creams there if you're using progesterone and
It's a very small amount. We put it in
Because
a
it really gets very rapidly
Absorbed.
absorbed.
Yeah.
I mean,
So
you've
you
got to
use
deal
less
with.
product.
I'm sorry.
you use less product?
Yes.
much less
Okay.
product, 1/4 the
Much
less
less.
product.
Yeah.
Okay.
Yeah. And so that's one thing. Second part is, of course, here in Santa Barbara, I'm in Southern California. We have a fair share of people that have stress levels off the chart. I'm talking about mental stress.
That's
That's okay. Mental stress off the chart. And these people are tired, but they can't go to sleep at nighttime.
It's totally me.
It's because, guess what? It's not because they have a high cortisol. You can measure the cortisol levels there, it's normal.
Oh yeah.
What they have is high levels of adrenaline.
Adrenaline.
The question then becomes is that how do you get rid of it? If you can get rid of that portion, now this is not a therapy for everybody, so this is between the physicians and me. But what I've done over the years is that once in a while, I'll give those patients, if like they're super agitated. Like I had one guy that travels to Toronto, to Brazil, to LA, and is his own private jets, and he has no idea what time zone he's in. He isn't half the time, right? He's traveling all the time, doing a movie shoot here and there, and just doing all kinds of work, and he can't fall asleep. I give one pill of active T3, which is thyroid, liothyronine, and guess what? It pushes all the adrenaline out of the cells. Boom, just wipes it off, and it's gone. Once it's gone, within 10 minutes, this guy's snoring.
So what's it pushing out of the cells?
T3.
Okay. No. So you're giving him T3,
T3.
5 micrograms, something like
10.
that?
10 micrograms. Of course,
Before
it's
bed?
a prescription item, so of course you're there to see
Yeah.
your physician. You have to
Yeah.
monitor all the other tachycardia and all the other things you have to do it. But that one thing, it just tells us that we can use medicine for temporary purposes for something that can gain control of the body.
Mhm.
And you can use it as a replacement as well for long-term purposes. But using the medication for the right purpose, for the right reason is what we need to do, working towards it. That's what I'm trying to get this point to it. There's
Absolutely.
Yeah.
little secrets that I've used over the years.
I like these. These are good secrets.
We're going to try that one. I'll be trying the glutathione, and Karen will be trying the T3. But
No.
we'll follow up with you,
Absolutely.
and we'll write a paper about it too.
That's my ultimate goal. And if you can take one, even
Mhm.
before you study it, register with the clinicaltrials.gov. That means if you don't publish
Okay.
it, they're going to ask you, hey, why did you publish it?
Yeah.
Right? Even if you see no results, I want to be published. I said, hey, I didn't get results. So then people don't waste time doing it over again.
Okay. Fantastic.
Oh, those were great.
To be
Yes, two-
continued.
two items.
Okay. It's
Yes.
been great.
Thank you.
Okay. We'll talk to you again soon. I really appreciate your time.
Now, if I need to be in touch with you about a couple things, is email a good way to be in touch with you?
Yes.
Okay, great.
Yep.
All
Yep.
right.
Okay.
Good
Thanks
deal.
very much.
And
All right.
do you have an Instagram account?
Yes, we do. We have one for the pharmacy at Central Drugs. We have one for the wellness, which is at Oral Wellness. And I'll send
Okay.
all those links to you. Absolutely. I'll
Okay,
send-
good. Yeah, if I can have those links, and I have the link to your website,
Yep.
and I can attach those in the episode.
Yeah.
That'd be great.
just
Okay,
drop-
great. Thank you.
Thank you so much.
Thanks.
for having me
Great.
today. Appreciate it.
Okay.
Bye.
Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.